So what we immediately think of in terms of osteoporosis is something like that, some kind of horror movie, something that involves a disintegrating spine, but that's not what it looks like. I think we really underestimate, underdiagnose osteoporosis. Probably, we probably see, maybe half of the people that come in to see us might be osteoporotic, and we never even discuss it with them. It looks like that. It looks like Bobby Clay, who ran the world's fastest mile until she couldn't anymore. It looks like that. It even looks like that, if you didn't know. This is one of the things that first comes to mind, I hope, for many people when we even say the word osteoporosis or bone density, anything like that, right? Your T-score graph that everybody's familiar with. We want our, as spine surgeons, we want your bone to be as rock hard as possible, but ideally also as pliable, right, as the world's hardest, most elastic substance, such as graphene. Thinking about Young's modulus, right? As strong as possible, but also as elastic as possible, kind of like toddlers or something of the like. And that's our ideal. Hopefully today we just get through the risk factors, clinical impact, and understand some of the basic science and pathophys. All right, today's really not necessarily surgical stuff. It's for us to kind of get into the clinic and talk more about this and think about it in a different way in terms of who we identify as having this or, truly at risk to have osteoporosis. So in terms of definition, a condition resulting in skeletal fragility as a result of low bone mass, microarchitectural deterioration, or both, okay? That's that classic picture that we always see in every, Google image or what have you. There's some interesting risk factors, and again, hopefully this just helps us to think of things in a different way. Weight, BMI, which we know about. Smoking, of course, comes to mind. A history of compression fractures in the patient or in a first-degree relative. Medications such as steroids, anti-epileptic drugs, Coumadin classically, alcohol consumption. Yes, the classic example is a postmenopausal female, androgen deprivation therapy, sedentary lifestyle or physical inactivity, and then low calcium intake for whatever reason. So yeah, it's true. I had some fun in looking this up, and thank God that the Koreans put so much literature out about this topic. But the true and exact mechanism for the weight related association and with osteoporosis, it's still not really understood, but it is associated with sarcopenia, and there's a lot of literature about it. You can go down several rabbit trails. But two that were interesting. Optimal body mass index for minimizing the risk of osteoporosis and type 2 diabetes. That was an interesting paper from a national database, and that BMI was between 23 and 25. Other paper on the bottom, underweight and risk of fractures in adults over 40 years using the nationwide claims database. These were patients, no surprise, with a BMI less than 18. And again, so this was another one, evaluation of the association between osteoporotic vertebral compression fractures and psoas major or paraspinal muscle mass, and the ADC measured on MRI. So, at the bottom, the vertebral compression fracture group was older with lower BMI and less muscle mass. No surprise there, but it's been fleshed out several times. Smoking, there is decreased formation of osteoblasts, neovascularization. This was an interesting, relatively recent paper about the process. Tobacco toxins induced osteoporosis through ferroptosis, which is a relatively newly described. I guess those who discovered it don't like to call it a form of apoptosis, but that's what it is. It's mediated by iron and the ER endoplasmic reticulum, but it is a form of apoptosis. There are epigenetic factors, genetic factors that influence your risk to develop osteoporosis, right? Epigenetic things being, again, lifestyle, where you live, what your diet is, and then, genetic factors such as what happened to your mom, your sister, her sister, so on and so forth. Medications that our patients take really, really make a difference. And there are things that we gloss over, but I think a lot of times sitting right there in front of us. Classic example is Coumadin, warfarin, right? This was a very good review of different anticoagulants and how they induce or propagate bone resorption. And so warfarin in particular, one of the ways it does so is through an enzyme called gamma-glutamyl carboxylase. There is a protein that we really depend on to, I would say, maybe finalize our hydroxyapatite, osteocalcin. And when this enzyme is not working well or not optimized, and obviously Coumadin has its effect on it, there's your risk factor for developing weakened bone osteoporosis. Phenytoin, age-old anti-epileptic drug, through increased activity of cytochrome P24. We remember that back in, I don't know, whatever year that was in med school pathology about revving up our cytochrome system in the liver. Well, it's kind of the same mechanism in that, vitamin K, vitamin D stored in the liver, those stores are kind of chewed through when you're on medications like this. I did go ahead and join the North American Menopause Society just to see what it was like. But it's funny. So the alcohol consumption, this one is, across the board, very, very straightforward. Many mechanisms are involved. However, malnutrition, including dysregulation of leptin, lower testosterone in men, which leads to decreased osteoblast formation and decreased estrogen in women, decreased expression of osteoprotegerin. It's funny, so if you look at this is straight from their website. So heavy alcohol intake, equating to more than 7 drinks per week, increases the risk of falls and hip fracture, and women smokers tend to lose bone more rapidly and have lower bone mass than non-smokers. Very straightforward stuff. I'm sorry for all the schematics, but when you kind of get into some of this is kind of what you find, and I'll be brief with it. Postmenopause is another risk factor. And if you look at the diagram where you see rank L there, but I hate that it's called that a lot. The other one, you remember rank ligand has a lot of different names. Osteoclast differentiation factor. Osteoclast differentiation factor is one of the other names, and that kind of makes its function much easier to understand when we talk about medications and how they inhibit, disinhibit, blah, blah, blah. And so if we look at the decreased presence of estrogen, osteoprotegerin is, if you let's just focus on the left side of the diagram. Osteoprotegerin is something that basically competitively inhibits the osteoclast differentiation factor or rank ligand. That was just a schematic also looking at the same thing, osteoprotegerin again. and rank ligand. Sedentary lifestyle is also a major risk factor for developing osteoporosis, and again, diagnosed. So this was, a long data set from China, but came to the simple conclusion that, you see in many cohorts, in many studies, the same conclusion. People who are inactive have poorer, weaker bone mass, bone density. There you are. Decreased testosterone. Key for this slide is aromatase. Remember that testosterone does get metabolized to estrogen and then back to the previous slide. Okay? And then lastly, low calcium intake, which I think is also self-explanatory. Yeah, so in looking this up, there are new things, and again, there are many rabbit holes to go down, but this was an interesting one. And I think our deformity colleagues are a little more familiar with some of this than the rest of us. But sagittal balance is also an important risk factor, right? This was literature put out by the Chinese less than 3 years ago. And so through the calculation of critical values, we found that when the SVA was more than 3.81 centimeters, future osteoporotic vertebral compression fractures were more likely to occur for every 1 centimeter increase in the SVA. The incidence of future compression fractures would increase by 0.324 times, and that was quite statistically significant. Interesting paper that with a small sample size, but also another paradigm shift into thinking about what the traditional risk factors are. We now, I thought these slides were important to include, maybe just to help us with maybe a slight paradigm shift in who we identify or are suspicious of, particularly in clinic. So from ACE, or the American Association of Clinical Endocrinologists, I don't know how familiar a lot of us are with what they say amongst themselves in terms of what should be done and what's recommended in terms of osteoporotic patients, how to work them up, diagnose them, treat them, blah, 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 so and the like. So I pulled some of this just so that I can discuss it with you all and make sure it's at the forefront of our minds. So first and foremost, who we think of, this might be one of the more important slides, I'd say. We traditionally, again, if we go back to that red, yellow, and green graph, think about where your T-score falls, right? Negative 2.5 or below, lumbar spine, femoral neck, total proximal femur, or 1/3 of your radius. That number one is what the vast majority of people think of and identify with. Number two is way more important, okay? Low trauma, spine or hip fracture, regardless of bone mineral density, okay? This is straight from their, their updated recommendations and guidelines. Low trauma, spine or hip fracture, regardless of bone mineral density. Number three, T-score between -1 and -2.5, so what we classically consider to be osteopenic, and a fragility fracture of proximal humerus, pelvis, or distal forearm. So number three is basically number two, but you have a Dexa scan that tells you the patient is osteopenic, not osteoporotic, right? And then number four, T-score between -1 and -2.5, and a high frac score as well. So I think it should just be diagnosis of osteoporosis, because once you bias yourself into saying that, it has to be some postmenopausal 60-something, 70-something year old little lady, you've already missed half of the people who are walking around with it. And again, number 2 is probably the most important one. So Dexa is still considered the gold standard. I know that a lot of people here are Team Hounsfield. I'm just going to say I'm Team Dexa still for a few reasons, and I hope I can kind of just illustrate why. I don't hate Hounsfield units or anything like that, but I still think Dexa is a little bit better if you go in regarding its capabilities. I think we all know what it means, but I'll go quickly again. Dual energy X-ray absorptiometry, X-ray of 2 different energies, X-rays of 2 different energies are used, factoring different absorption coefficients with the difference between the total absorption measured between the 2 X-rays. There's our green, yellow, and red graph. Again, first thing that should come to mind in general. What a lot of people don't know is that a Dexa, and I love that there's a little person inside of this person. I'm just wanting to get out. I love that a Dexa can also give you a body composition, right? A fat content. So it's a little bit, okay, yes, most, how many times have you ever asked for this? Never, right? But it's something that you can actually ask for. If you actually ever, for other reasons wanted to know what percentage of this patient, this is just a great example, what percentage of this patient is bone, what percentage of it is, of the patient is other stuff. You can get that from a Dexa scan.
Hey, Akwasi, so I see a fair number of patients that are going to these wellness centers, and they'll do the full body scan. And I've always wondered about the accuracy of the bone density. I mean, they'll show pictures like this, and they'll give, readings about muscle and everything else. So are they just as accurate as a dedicated Dexa scan, or?
You're saying like a full body?
Yeah, they'll do a full body scan.
It's basically a full body Dexa scan.
Yeah.
Yeah, because we used to be able to do that years ago. We had
Did we?
Yeah, it's the same thing.
Yeah, but they're quite accurate, actually. We don't use them as much here. We don't do as much, I guess they do much more body shaming overseas, but I mean, it's a pretty accurate additional test that you can do to say a little bit more about someone's bone density in terms of what your bone actually contributes to your overall percentage or composition. I think maybe more of the bone doctors are familiar with the trabecular bone score, but for people like me, this is another study that the Dexa, the traditional Dexa, can give you, and just as another measure of the microarchitecture in a particular structure, femoral head, traditionally L1 to L4. Here's just a quick example of the FRAC score. It's something that you can quickly calculate if you're concerned about someone's bone density and you have something important coming up. We're all familiar with it. It was originally developed at the University of Sheffield in 2008, and then more widely adopted at HSS in 2010. So I'm going back to some of the diagnostic criteria just for a second. So remember, with your Dexa scan, being osteopenic or having a T-score between -1 and -2.5 with an increased fracture risk, meaning, at least and it'll give you different values depending on, I know you saw the flag on the slide, but it'll give you different values depending on which part of the world you're in. And it's a very, very quick thing that you can do to possibly alter how you're gonna plan an operation for someone, or even preoperative treatment before you ever get to the OR. Hounsfield units, a voxylated measure of radio density used by radiologists on CT, in which there is a linear transformation of the linear attenuation coefficient. Oh my goodness, can't believe I even just said that, right? So most of us are quite familiar with Hounsfield units, or CT number, as it's also called. I think, how many people love using Hounsfield units other than Dr. Staub?
I don't love it, but I use it as a comparison with the Dexa.
Yeah, so Hounsfield units are actually quite good in the literature. I don't think you need me to tell you how to calculate them, but should anyone, this is kind of standard how it's done. Some people will actually use their region of interest or ROI on both and then average, right? Some people do sagittal. Do you do both sagittal and axial? Average them, or you just use your axial ROI?
I actually just use sagittal, and if it's questionable, then I'll go to the axial.
Yeah, I'll do both quads and I compare them.
Yeah.
What's your cutoff?
I have a chart that Dr. Geyerson out like.
So the numbers you need to remember.
Below 120 is osteoporosis.
So here are the numbers, at least from the literature. It's 190 plus or minus 50 is normal.
Yep.
Osteoporotic is 120 plus or minus 30, so that, or osteopenic that is. So that's the rub, because you could be 150 and be osteopenic, or you could be normal according to the 190.
So for me, it's below 120, you need work. It's above 120,
Right.
I'll operate on it. It's kind of
That's exactly right.
when they're 90, I shriek.
Do you get with Dexas as well, or that's
No,
a little?
because a lot of my patients get pre-op CT scans, and the Dexa we're like, oh, the spine's great, and everyone gets confused because they're all sclerotic and their spine looks good on a Dexa, but in reality, their bone's terrible.
In the patients you're operating on, Blake, a lot of them will have peripheral osteophytes, and that's going to affect the
That's what I'm
DEXA.
saying, yeah, exactly.
And that's why probably the Hounsfield units are more accurate than those
Sure.
cases.
And also for me, I like looking at like where the upper vertebrae is going to be. There's some recent studies showing that if that's like horribly osteoporotic, then maybe you should go higher. Because if you're to stop at T10 and there's like, you're measuring 90 Hounsfield units, that's probably not the best place to stop.
Perfect.
The lit review, just kind of trying to compare. We do have papers with, like they were only doing the Hounsfield at one level, things like that. And just kind of roughly weighted average, 120 and below, osteoporotic, 170 and above, probably okay.
So for
I guess for those of us who don't regularly use, it, I use them pretty often also. But I would just say if you don't regularly use it, maybe once or twice, in an upcoming clinic on a patient who has a CT, who bone density is not even, something that you've discussed or was at the forefront, just go ahead and measure their Hounsfield units. You'll be surprised by what you find in a lot of your patients. The point is, have your way of just assessing, bone quality beforehand.
I might add that if you get a Dexa scan and you have a CT, just compare the two so you get an idea of the variation and sometimes the correlation, but there's always little variation. And what he showed on the picture how to measure, for those of you that don't, the mid-sagittal view is really good. When you use the axial image, you want it to go at the mid-body, and you want to make certain you're away from the cortex and also away from where the nutrient vessel enters the posterior aspect of the body. So, because that'll lower your number. So just like what they showed there, that's pretty good.
I would make a plea for, this is information that every radiology report should see.
Absolutely.
The CT is done with a bone on it. Give me the Hounsfield.
Absolutely.
They should, Ted, but
Well,
yeah.
I think you're going to start seeing some software that's able to segment the spine and give regional Hounsfield units.
I think as long as radiologists are billing for making reports, they should be willing to do simple things that are actually clinically useful, as opposed to measuring the diameter
But-
of the mid-sagittal cut.
I like when they
canal.
Except that-
put stenosis as a percentage.
Well, we've all had a CT and immediately said, oh, this bone is absolutely terrible, right? Without calculating a single Hounsfield unit. But there's nothing said about, once in a while you get a comment about the actual bone quality or bone density, but I agree with you. I mean, it takes them 1 second to do it.
It would take them, but you know, you compare the MRI report, sometimes they'll say, some mild changes at L4-5, and then you'll have somebody that lists every little thing, and there's some minor facet change, and thickening the ligamentum. There's no uniformity. That drives me nuts about that.
And then you have to go through level by level with
Yep.
the patient and explain why their disc bulge at
Yes.
012 is
That's
not
the worst.
problematic.
That's the worst.
Do you measure the bone density in planned UIB +1?
Say that more.
So I think, I don't know if it's published, but I reviewed it for, I think, NAS, but Lanky looked at his rate of PJK and PJF, and it seemed to be not necessarily obviously the bone density matters, but more so the delta between your
That's
UIB
published.
and UIB +1, and if the UIB +1 is obviously way less quality of bone,
Sure.
or quantity of bone rather, that is a poor prognostic or is a risk factor for having PJF. So
Yeah, I can't. For me, it's like if I measure T10 and it's fine, I'm not gonna just like measure every point, hoping to find a bad one. I just go, oh, look, it's good. If T10's like 121, you know, like right on the border, yeah, maybe I'll go up a level and see what it looks like.
but I think it's not necessarily the UIB bone density, it's that change.
It's the one above that. But
Yeah.
what's interesting though is, okay, so let's say the UIB looks good, and then you look at the next one and it's bad, and you didn't cement that. There's data showing that cementing that makes no difference, right? So then, does that invalidate the studies showing that?
I think there's data that shows it helps prevent acute PJF.
But doesn't it just happen at the level above that?
Probably.
Right.
Well, then it's no longer adjacent. So
It's no longer judgmental, it's just normal diagnosis.
I mean, perfect. So that's kind of the point of this all, because this is stuff that is on everyone's mind, and the point is just that there's, at least in terms of the Hounsfield unit or CT number, there's a lot of literature available already to say that's a pretty good way for you, and it's, you know, it's pretty quick. There's a lot of literature to basically say, you know, it's a good way for you to estimate someone's bone quality. Again, it's still not considered the gold standard, and again, there are other reasons why, right? What else can a Dexa provide you? But it's quite good. The paper on the top, which indicator among lumbar vertebral Hounsfield units, vertebral bone quality, or Dexa, measured bone mineral density, is more efficacious in predicting thoracolumbar fragility fractures. This was a relatively small sample size, but for Team Hounsfield, yeah, it was more accurate in predicting fragility fractures than the Dexa. Probably for, right, and I mean, what we just discussed in terms of when you measure a Dexa in certain individuals, sometimes you're not getting a clean number. Sometimes you're not getting a clean number, right? The osteophytes are being factored in, and you're overestimating someone's bone density when it's really quite poor. So again, I really challenge you, just one or two people whose bone looks normal, just calculate the Hounsfield units in clinic and just see what it shows. The bottom one could CT Hounsfield unit values of lumbar vertebrae detect osteoporosis. Yeah, I mean, this paper really just showed the correlation with Dexa to be quite significant, to be quite high, and also was a small sample size. But the point is, it was not significantly inferior. Vertebral bone quality. I'm not sure if many people are familiar with this one. This is something from the SOSG, Spinal Oncology Study Group, from relatively recent, but it's a new MRI-based measurement, ideally also in a mid-sagittal cut, T1 weighted. There is also a T2 weighted version of it, but usually T1 weighted image using medullary L1 to L4 region of interest, with the last ROI of CSF behind the L3 vertebral body. Those are the standard values for vertebral bone quality, listed in red down there. It was out of Hopkins in 2020, and originally was out of some of the oncology patient subset from Hopkins, showing that it was something that could also help to predict or attempt to predict bone quality off of an MRI, classically a T1 weighted image. And then this paper on the bottom, intraoperative surgeon assessment of bone, correlation to bone mineral density, CT Hounsfield units, and vertebral bone quality. This is a European paper, basically using a Likert scale, like kind of your gestalt about how you feel about something, really good, somewhat, right, or really bad. And in terms of correlation, the vertebral bone quality was quite high in this, and a little bit higher than the Dexa, but the Hounsfield unit was actually number one in that one as well. This is just an example of how the vertebral bone quality is calculated also. Let's say you have nothing and you just want to get a good idea of what the patient's bony architecture looks like. This is how it's calculated. So back to our friends from ACE, or the American Association for Clinical Endocrinologists. Vitamin D is supposed to be checked, measured, treated if it's low, right? So measure serum 25 hydroxyvitamin D in patients who are at risk for vitamin D deficiency, which is basically everyone who lives in the Northern Hemisphere, particularly those with osteoporosis, kind of straightforward. The recommendation is to maintain a serum 25 hydroxyvitamin D greater than 30, particularly in patients with osteoporosis. And I don't know, this is information that I guess is not standard for us. Alcohol again, so I just like the alcohol slides. Counsel patients to limit alcohol intake to no more than 2 units a day. So different organizations around the world have different values for what a unit is, believe it or not. So when do you even start treatment? Pharmacologic therapy is strongly recommended for patients with osteopenia or low bone mass and a history of a fragility fracture of the hip or spine. Radius should be included in there. So that's a lot of people that we see in our clinics and overlook. This is interesting to me. This is straight from their guidelines, okay? Ibandronate or raloxifene may be appropriate initial therapy in some cases for patients requiring drugs with spine-specific efficacy. How many of us have ever referred someone or prescribed either of these? Yeah, straight from their guidelines. And then also, vertebroplasty and kyphoplasty are not recommended as first-line treatment of vertebral fractures, given an unclear benefit on overall pain and a potential increased risk of vertebral fractures in adjacent vertebrae. This is the horse's mouth. So just quickly into some of the medications. There are 2 major groups, which are anti-resorptive medications and anabolic medications. Alendronate, ibandronate, resendronate, zoledronic acid, those are our bisphosphonates. Zoledronic acid is a nitrogen-based bisphosphonate, which you only infuse once a year. We are all familiar with Prolia, raloxifene, bazidoxifene, estrogen therapy. In a quick summation of bisphosphonates, their major role is to basically be on the front line and inhibit osteoclast activity. Downstream activities include increased osteoprotegrin production and decreased rank ligand, decreased osteoclast differentiation factor expression. So bisphosphonates are frontliners. This is zoledronic acid, which is also, again, just a nitrogen-based bisphosphonate. On the right, you see Prolia, which is a monoclonal antibody designed to bind to rank ligand or osteoclast differentiation factor. Raloxifene basically works through, it's an estrogen upregulator, and it's osteoprotegrin based. And then the other major group are anabolic medications, teriparatide or Forteo, abaloparatide or Tymlos, and then romosozumab, Evenity. I think the newest of these is Evenity. Quickly on the diagram, you see Forteo and Tymlos acting at the level of the mature osteoblast and basically binding to a PTH receptor. I guess a lot of times, quickly when we discuss, Forteo, many people think that it works on the osteoclast level, but it's really the osteoblast level. The PTH receptors are at the osteoblast level. And lastly, so a quick thing is that Forteo, Tymlos, 2 years max. We've discussed the risk of developing a malignancy after 2 years with both of those. Evenity, 1 year, typically 1 year max. And those are injections in clinic once a month. And here's its mechanism of action. Mainly binds to sclerostin. A few quick things just about procedural and surgical adjuncts. Everybody here is very, very familiar with vertebralplasty, but maybe not so much about the history of it. 1984, developed in Amiens, France, by Doctors Galibert, Deramon at the University Hospital for a 54-year-old female with a C2 hemangioma with epidural extension. And this was done via an anterolateral approach with complete pain relief. This was revolutionary. There's the paper down there. It was quickly adapted by surrounding surgeons in France, and it wasn't really adapted here until later on. I guess some of you guys in the room may even know Dr. Riley. I'm pretty sure some of you do. This is what happens when you sell Kaifon for, almost $4 billion. You paint things because you have time to paint things. So in terms of, vertebralplasty, just a quick word, this was from the New England Journal. And if you look down to see, how powerful are vertebralplasties and how did it become so widely adopted? Just look at this. So in terms of this paper, 68 vertebralplasties, 63 simulated procedures, similar baseline characteristics. Obviously, that's what you always want. At 1 month, right, there was no significant difference between the vertebralplasty and the control group. or their pain ratings. Both groups had an immediate improvement in disability and pain scores after the intervention. Although the two groups did not differ significantly on any outcome measure at 1 month, there was a trend toward a higher rate of clinically meaningful improvement in pain in the vertebroplasty group. Okay? So at 3 months, there was a higher crossover rate in the control group than in the vertebroplasty group, and then one serious adverse event in each group. That's one of the big vertebroplasty papers. I mean, this made it to the New England Journal. I guess if it were not so widely practiced, and I try to convince somebody based off of this paper that this is probably something great, new, good that we should be doing, I don't know that I'd be successful. Dr. Mark A. Riley, if you don't know who that is, I guess, one of the founders of CAIFON. He was an orthopedic resident. Does anybody know Dr. Riley? Any of you guys know him? Yeah. He was a resident when he first started, was he? I think so.
I didn't know that. I'm not sure he was a resident.
Yeah, I think so. I think he was a resident.
Very bright guy.
Yeah, and then started actually doing them out of training, kyphoplasties, and then developed the vertebroplasty, the inflatable. They coined that term, inflatable bone tamp. Profits went up and up and up and up and up. More and more people started adopting vertebroplasty and then kyphoplasty, and then CAIFON became a huge thing, and then they sold it. So 1994 it was founded formally, and the first kypho was performed in California in 1998, right after the FDA approved it. Another one of his ventures, yep. Since, cement, these are things that everybody is familiar with, but just for our knowledge, it's different now, but since 1993, people have been, maybe even before then, people have been using cement augmentation of pedicle screws, and obviously it was done differently. It was quite stressful, right? The old school way before the advent of fenestrated screws, having to cannulate, make sure the cement doesn't harden, inject it, and then hurry up and get the screw in. Fenestrated screws have been awesome in that regard. But again, they've been around for a while. This is from 2009, cement augmentation of pedicle screw fixation using novel cannulated cement insertion devices. We have a local expert about the topic as well, showing that there was undoubtedly an increased pull-out strength with cement augmentation of pedicle screws. This is a paper from Hopkins. We're all familiar with HA screws. Has anybody ever removed any HA screws?
I've been tempted to remove an HA screw.
Unbelievable, right? Yeah,
I couldn't get them out, no matter how hard I tried. It was from a TOPS device, and they're just stuck in there.
Yeah, unbelievable.
But also, the problem is you don't know sometimes when you go in there, and then it changes your surgery quite a bit. It's also quite expensive.
which is why we love the cement augmentation.
So that never had to take one of those out. Just the bone just grows into it and you just can't turn it.
Wait, what do you do?
Yeah, you cannot turn it. I mean,
No.
there's
You cannot turn it.
every screwdriver you use, nothing happens.
Yeah.
It's like it's cement.
And the funny part about it, I was extending his fuse, his top device broke down, and I was gonna take out those screws and put new ones in. And as we were taking them out, either me or the fellow dropped one of the locking caps, and we didn't think of the 5-second rule. So we had to not put a, lock on that, we went above and below, but yeah, they would not budge.
Yeah, you will actually fracture the pedicle before you get the screwdriver off.
They're very effective, but don't ever take them out.
So if you get one of those, just leave them in and get a new rod, take the rod up higher.
Yeah, that's it.
And because then also I've never put one of those things. It's like, does everybody make those? Like Medtronic, DePuy, everybody.
I'm not sure.
And Synthes does.
I'm not sure what the point of it.
Medtronic's on wound up makes it.
Doesn't make the bone stronger.
That's what you want, right? You want
Stronger. And they're just
Basically, not pull out, but
incredibly expensive.
infusion.
Unless they get loose because of osteoporosis.
Right, and what's the point, right?
So I don't think it's, I would not imagine that it would really actually solve the problem at all.
It's gonna
Just
increase
creates
rod
a
fracture.
revisable screw.
And then
Ever use them? So that's all of us. So conclusions, osteoporosis is underdiagnosed, particularly in patients undergoing spinal procedures. There are a host of diagnostic and therapeutic options. Spine surgeons needn't wait for other specialists, subspecialists to initiate interventions and/or diagnosis. Thank you.
All right, thank you, Akwasi.